Thank you very much for the opportunity to talk about this.
So with the green one, you go on.
Great. So I have no disclosures, but I do have a statement, which is that we really don't have a lot of data guiding the topic that we're about to discuss, and so hopefully you guys will just come on a journey with me, and hopefully we'll each leave with a consensus that we feel pretty comfortable with. But there's really no right or wrong answer. So I thought that we'd start by doing a brief overview of the imaging modalities that we currently utilize for cross-sectional imaging of pancreatic neuroendocrine tumors. So somatostatin receptor PET dotatate scans are most commonly here in the United States. We use gallium dotatate PETs. We typically use these to fully stage people with disease at the time of diagnosis. And specifically, this is very helpful to assess for distant metastasis, for nodal metastasis. And it does also assess the somatostatin receptor expression, which does have therapeutic implications later on down the road. At times, we will integrate this into restaging for patients that have either suspicious progression or recurrence. It can help confirm a recurrent disease, but in general, we don't routinely use this for surveillance. So CT scans, contrast enhanced and multiphasic, tends to be the preferential mode of cross-sectional imaging for surveillance. And it's very helpful for multiple phases. In the preoperative phase, it's very helpful to assess the tumor vascular interface, which helps for preoperative planning. And then for local recurrence rates, as well as for nodal recurrence, I think CT scan is a bit superior. And then MRIs of the abdomen, I typically use in the setting of evaluation of liver metastasis. The sensitivity of evaluating both the volume and distribution of liver metastasis is higher for MRI, and so I almost always get these in the preoperative setting. For surveillance, I typically use MRI to help differentiate between indeterminate CT findings, or in younger patients where we're concerned about a lifelong exposure to radiation, we can alternate with MRI and CT scans. But before we talk about surveillance, we really need to talk about recurrence. And we need to talk about how often and when does this occur. And this helps guide what we think we need to do for surveillance. So again, not a lot of data, and in 10 minutes we can't go over too many studies, but I wanted to talk about this one study which I thought was quite helpful. So this is a retrospective multi-institutional study that looked at over 1,000 resected pancreatic neuroendocrine tumors, both functional and non-functional, and they had a median follow-up of about 135 months, so very long follow-up. And the mix of this patient population was quite good. About 30% of these were G1 tumors, 37% were G2 tumors, and then about 3% of them were G3 tumors. 85% of the patients underwent R0 resection, and the overall recurrence rate over the study period was only 15%, so relatively low. What was interesting is that 50% of all of those recurrences happened within the first 2 years. About 75% of them happened within within the first 5 years. And so the vast majority of patients that recurred do so quite early. All of the patients that recurred had recurred within 10 years of their initial surgery. Predictors in this study of recurrence included tumor grade, margin status, genetic syndrome, all of which were prognostic of recurrence-free survival. Almost all of these patients failed in the abdomen. Only 2 patients had lung-only metastasis, so that was a recurrence rate outside of the abdomen of only 1.3%. So I think this is kind of important. It helps us figure out how long we should be following these patients, perhaps when to ramp up and when to ramp down the frequency of our surveillance, and also clearly tells us that we need to really primarily focus on the abdomen. So in general, just to summarize what we talked about a little bit, again, the somatostatin receptor PETs are really good for staging, but not for routine surveillance. And again, we really only use them to confirm recurrence or progression. CT scan is preferred, and I think there are some considerations, patient age, which we talked about, the location of the lesions being followed. MRI certainly is very helpful for liver lesions, but based on the data that we have, there's really not a lot of evidence to support routine chest imaging surveillance for these patients. As we discussed, almost 98% of them or more will recur in the abdomen, and we will catch these recurrence on just abdominal surveillance. But there's no consensus on how frequently we should survey these patients. And so I'm gonna talk a little bit about what I do, and which is a meld of, I think, some of the consensus guidelines from pNETs and pNETs. So for high-risk tumors, these are tumors that are larger, node positive, or have high grade. I typically get baseline imaging about 3 to 6 months after resection, just to demonstrate what their new baseline is. In terms of duration of surveillance, I think the abundance of data suggests that 10 years is adequate to survey these patients. We do have late recurrences because this is an indolent disease, but the vast majority of people will definitely recur within 10 years. The frequency, again, no consensus, really varies a lot by the recurrence risks. And this is where I think we all need to be very thoughtful about our individual patients and our practice patterns. So for very favorable tumors, so G1 tumors, node negative tumors that were relatively small, I typically survey these patients with annual cross-sectional imaging for 10 years. For patients that have either node positive disease or grade 2 disease, I typically do cross-sectional imaging for 6 months for the first 2 or 3 years, and then annually after that for 10 years. And then for metastatic patients that undergo curative resection, we know that their risk of recurrence is much higher than the other cohort. Those patients I do follow a little bit more closely, usually every 3 months with cross-sectional imaging for 2 years, and then every 6 months for the next 3 years, and then annually after that. Again, I think the most important thing to remember is most patients will recur within 5 years, and about half of them will do so within the first 2 years. So I think paying close attention to high-risk patients in those first 2 years is really important. For functional pancreatic neuroendocrine tumors, I think it's slightly different. Insulinomas are the majority of these. They tend to be very benign. They tend to respond quite well to surgery and don't recur. They also have a clinical syndrome that is almost always apparent when there's recurrence. So I think the impact of cross-sectional imaging in these tumors is actually much lower. And I think really we should be driven by the size. We should be driven by symptoms and the serum biomarkers on when to reimage for these patients. For other functional pancreatic neuroendocrine tumors, size, grade, extent of disease, symptoms, similar to what we do for non-functional tumors, because those have a higher metastatic potential. So what about serum biomarkers? Well, I think everybody knows chromogranin A got a lot of attention years ago as it was implicated in prognosis for neuroendocrine tumors, and there was promise for the applicability of this serum biomarker in surveillance. This is a study that looked at patients who underwent curative resection. The recurrence-free survival rate was 73% in this group, and what they did was they assigned, they looked at prognostic factors that were associated with recurrence. That included elevated chromogranin A, which was defined as 5 times the upper limit of normal, tumor grade, whether the resection was for primary disease or recurrent disease, and then tumor size. And they assigned a point for each of these. And what they found was that for patients that had 0 points, so patients that didn't meet any of those criteria, it was about a 95% negative predictive value for recurrence. So those patients did really well. And so anybody that scored 1 or higher, you would consider higher risk. But unfortunately, that really didn't pan out when we expanded these to other disease centers. And so I think in general, chromogranin A is nonspecific. It's quite promiscuous. And at this point, we don't routinely recommend it. But there's some new biomarkers that are on the horizon. So I'm going to briefly talk about the NET test. So NET test basically was initially reported in 2019. in this study that looked at 153 resected neuroendocrine tumors. About 50, I think 2 of these were actually pancreatic neuroendocrine tumors. The others included GI, NETs, and lung. And they did a blood sampling at post-op day 0 and post-op day 30, and did MRI quantification by PCR to basically measure microscopic disease. Cutoff of 20 is considered normal, and they followed these patients with cross-sectional imaging at regular intervals. The NET test in this study was positive in all of the patients on post-op day 0, which meant that it was accurate for predicting disease. In patients that had R1 or R2 resections at post-op day 30, all of those patients also had a positive NET test. In patients that had R0 resections, however, it was interesting, 30% of them remained NET test positive at postoperative day 30, and about 18 months after, about 81% of those patients had identifiable recurrence. So I think this was a very exciting study. It certainly prompted a lot of conversation and thought. This was their probability of recurrence-free survival based on a positive test. But I think there were several things that I think raised questions and I think warrant further investigation. This is typically a very indolent disease, so I think recurrence rates as high as they were within 18 months is a little atypical. And I think we need to obviously expand this test to more cohorts to make sure that it's widely applicable. So in summary, I think that we don't have a lot of data guiding us, but it does appear that duration of surveillance should probably be limited to at least 10 years. There's variable abdominal imaging frequency, and that should be based on grade, tumor size, and functionality. Very little data to support routine chest imaging in these patients, as they're most likely to fail in the abdomen. And there's really no consensus on routine biomarker use in a monitoring of non-functional pNETs, even though there's some promising tools on the horizon. So that's all I had, and this is our pancreas program at MCW. I welcome any questions.